When you look at particular gaps, like maybe more high-risk populations over others, we have to look at our ethnic population, the different races, because unfortunately most of the studies, especially done here in the United States, constitute constitute a population that are typically Caucasian more so than the non-Caucasian counterparts. We need more data. We need more study subjects to participate that are of Asian, that are of Black descent, that are of Hispanic descent, because those are really the high-risk groups. They tend to have diabetes at a much higher rate than the non-Hispanic white. They also tend to have complications at a much higher rate, and they tend to have higher mortality as well when you compare them to the non-Hispanic white. So we have ethnicity and race differences that need to be addressed. We have the underinsured. So while we were fortunate with the Affordable Act to make sure that everyone had access to health insurance, and we were able to check off that box, the type of insurance patients have, sometimes they may as well not have insurance at all, because the deductible that they have to pay out of pocket before their health insurance actually kicks in is costing them way too much money, and they can't afford to come to appointments. They certainly can't afford some of their medications. Again, diabetes is a buy one, get three free disease, so you're usually contending with hypertension, dyslipidemia, underlying heart disease, and so there's other medications, other specialist appointments, other co-pays that have to be taken into consideration. And so it makes managing a complex disease like diabetes, where there is so much overlap and association with other comorbids, very difficult and very costly for our patients. Our patients that come to us from different cultural backgrounds have a different approach to their health care, a different approach to medication taking, a different approach to how their relationship is with the provider that's supposed to be assisting them. There's different dynamics within the family, who's allowed to speak, who's not allowed to speak, who has to be present at the appointment. So our approach to our patient has to take in these cultural issues that come into play that can either be exploited in their benefit and be used to enhance the appointment, or can actually act as a barrier if we don't understand what those relationships are and how to either work with them or overcome them with the patient. There are courses that are being made more available, so I would definitely look into what's going on around you as far as educational programs that are offering some of this. Maybe touching base with the colleges and universities in your area. They may have some courses that you can take even as an audit, but it's very important that whatever we do, because again, we bring our own biases to the equation, and not understanding where someone else is coming from can actually taint the waters and hurt that patient-provider relationship and the trust that we need to establish before we can do anything as far as managing their health.